Thanks a lot. Good afternoon, everyone. This will be really a last man standing presentation, so thank you for your patience. Actually, the title can be also shorter, from decompensation to catheter ablation. And this is a case, these are my declarations of interest. This is a case about a 73-year-old lady with HFpEF. It is my patient. She presented after recent decompensation for heart failure based on atrial fibrillation and infection. Her comorbidities are standard comorbidities. She was well treated with guideline-directed medical therapy, and she was stable. During the checkup, we showed on the ECG there was recurrent atrial fibrillation. The echocardiography showed preserved ejection fraction with diastolic dysfunction grade 1, so normal filling pressures, and her NT-proBNP was mildly elevated in the context of atrial fibrillation. So we recommended the patients, in accordance with the guidelines, to repeat the cardioversion, which was initially successful, but after some time there was a relapse of atrial fibrillation, recurrence of atrial fibrillation. The patient didn't like this procedure, and because it was not successful at the first attempt, she refused it. We also suggested her to undergo catheter ablation, which she also didn't like. And then we also recommended her telemonitoring because of symptomatic heart failure, which she accepted. We used a novel non-invasive system for remote monitoring of left ventricular filling pressures, which is a novel system that uses a simple pulse oximeter that records photoplethysmography. It's done 2 minutes in standing and 2 minutes in the recumbent position. The data are then analyzed on a secured cloud, and we can get left ventricular filling pressure out of this analysis, which are together with other vital parameters and symptoms displayed on a physician's dashboard. Few weeks after the medical checkup, we showed during the monitoring that her filling pressure started to go up. Sorry, this is a very granular graph. This is 1 year of monitoring of left ventricular filling pressure, so perhaps not everything is that good seen here. But once we spot the increase in the left ventricular filling pressure, we asked her to come again for a medical checkup. And in accordance with the monitoring, we showed progression of the tricuspid regurgitation. The gradient now was 35 millimeters of mercury. So there was a progression from the initial 28. Also, there was an increase in NT-proBNP. So we increased the dose of furosemide. The filling pressure normalized. But during the course of 1 year, there were many elevations of the filling pressure with the need of frequent either phone calls or medical checkups with frequent medication adjustments. So finally, we were able to persuade the patient to undergo pulse field catheter ablation, which was done here. And very nicely after the ablation, the filling pressure normalized, and it's now more than half a year that we are monitoring the patients, and the filling pressures are stable. There was no need to contact her again, except of the, of course, standard medical checkups. So to summarize it, atrial fibrillation, as we know, is a common comorbidity in heart failure patients. Half of them will develop atrial fibrillation or already have atrial fibrillation. Cardiac filling pressure increases 3 to 4 weeks before heart failure decompensation, so it is a very good marker to look at, and based on which the therapy could be adjusted, which leads to improved quality of life, decreased hospitalizations in some cases, for example, in HFrEF patients, also to reduce mortality. And there are novel systems for non-invasive remote left ventricle filling pressure monitoring, such as we used in this case the Seerlinq system, which can be cost-effective and non-invasive substitution to the invasive devices that are available nowadays. Thank you for your attention.
So thank you for a great case, great presentation, and a really nice illustration of why rhythm matters in heart failure. Do we have any questions? So I have a question about your monitoring system, because it's not one that I know. So again, excuse my ignorance. How reliable is it? What are the false positive, false negative rates with it? What are the limitations of its use? Are there certain patient populations where it's just not valid? Could you just tell us a little bit more about it?
Yeah, sure, and you don't have to apologize for your ignorance at all, because it is a newly introduced system. Yesterday I had a late breaker presentation where for the first time we showed the results of our validation study.
Okay, I feel a bit better now. But anyway, tell us a bit more about it.
Okay, so it is reliable based on the validation study I presented yesterday. It obtained the C marking, and it is the class MDR2B, which is a more strict class. So it is actually, we can say it is the world's first CE-marked medical device for non-invasive remote monitoring of left ventricular filling pressures. It has strong correlation. I mean, the output of this algorithm, I don't know to what details should I go, but the output of this AI algorithm that analyzes the photoplethysmography curve can be transformed into left ventricular filling pressure. There is a strong correlation between this parameter, which we call diastolic reserve index, and the cardiac filling pressure. There is near perfect classification between elevated and normal filling pressures. It works also in patients with atrial fibrillation, as we saw here. Also in patients with valvular diseases. Where it doesn't work are the patients with precapillary pulmonary hypertension. Also there is a need to do this hemodynamic maneuver, if we can say. So there is 2-minute measurement in standing and 2-minute in recumbent position. So some patients are not able to, if they are immobile, for example, so these patients can't use this device. And we have now first results of a clinical validation, which shows great results. Unfortunately, I can't tell you more because it will be presented at the ESC in Madrid. I would say some of the limitation is the quality of the signal, because basically one of the most important things that the AI algorithm does is the denoising and artifact removal from the PPG, from the photoplethysmography curve. And is also required that patients have their hands still when they are measuring their PPG with the pulse oximeter. So if that's not possible, then sometimes the quality of the signal is not very good, and we have to, or the patient had to repeat the measurement. And it's true that sometimes in case of atrial fibrillation, there is higher risk of being of lower quality of the signal. So sometimes patients with atrial fibrillation have to measure more frequent. So, yeah.
Thank you very much.
Great case and great data. One clarification: what is the cross-validation against? Is it against hemodynamic right heart cath data, left heart cath data, and diastolic pressure, LV and diastolic pressure, or is it like echo data? What was your validation against?
So both, as I mentioned yesterday, I presented two cohorts. One were patients which underwent right heart catheterization. So the pulmonary capillary wedge was the golden standard against which we compared our algorithm. And we had another echo cohort where of course, there was only classification of elevated filling pressures or filling pressures into normal or elevated based on their diastolic dysfunction. So this was a second cohort. But I mean, we validated it also against right heart cath.
Okay, and this was for both preserved and reduced ejection fraction?
Yes, yes.
And one last thing, based on what I could see on the x-axis, your cutoff for normal or elevated filling pressures was 15 millimeters of mercury, is that correct?
15, yeah. So there are two cutoffs. There is a bit mistake in this picture because there is missing another cutoff, which is 25. And this is also very interesting that unfortunately, fortunately, these patients never went into the red field. But we are now monitoring more than 300 patients, and we really see when they hit the 25 cutoff, they start to have symptoms, and I mean, it's really alarming. So, I mean, ideally is to keep the patients in the green zone, so below 15 millimeters of mercury. On the other hand, as you can see here, I mean, there were many times that this patient surpassed this limit, but still she was most often symptomless. But the problem is when they hit the 25 millimeters of mercury.
Thank you very much. Any comment or question from the audience? Professor Price?
No, a great case. So thank you very much. And I'd like to thank all the presenters. I've learned a lot.